Our speaker tonight hasn't written a work of fiction to call us out of our somnolence and moral blindness, but he has written a number of books. And more than that, he has crafted a life of meaning and purpose and enormous inspiration, a life that challenges the rest of us to do what we can to help before it's too late. Paul Farmer is a medical anthropologist and a physician who's dedicated his life to treating some of the world's most disadvantaged populations, poorest populations, in the process helping to raise the standard of health care in underdeveloped areas of the world. He's a founding director of Partners in Health, which is an international charity organization that provides direct healthcare services and undertakes research and advocacy activities on behalf of those who are sick and living in poverty. He and his colleagues have successfully challenged the policymakers and the critics who claim that quality health care is impossible to deliver in resource-poor areas. Among those colleagues, for over 20 years, is Ophelia Dahl, who's out of the country right now. She's executive director of Partners in Health, and she is, I'm very proud to say, a Wellesley alumna, a Davis Scholar from the class of 1994, and a very important part of this impressive story. Dr. Farmer has worked for over 2 decades to control infectious diseases in the Americas and is a world-renowned authority on tuberculosis treatment and control. He's an attending physician in infectious diseases and chief of the Division of Social Medicine and Health Inequalities at the Brigham and Women's Hospital in Boston, and the medical director of a hospital, the Clinique Bon Sauveur in rural Haiti. His work draws primarily on active clinical practice and focuses on diseases that disproportionately affect the poor. He began his lifelong commitment to Haiti in 1983 while still a student, working with villages in Haiti's Central Plateau. The following year, he began medical school at Harvard, and 2 years later, he helped found Zanmi La Santé, which is Creole for Partners in Health, serving as its medical director from 1991 to the present. Boston-based Partners in Health was founded in 1987. Zanmi La Santé has grown. It's a beautiful language, as you've said, a beautiful language. Zanmi La Santé has grown from a one-building clinic in rural Haiti to a multi-service health complex that includes a primary school, an infirmary, a surgical wing, a pharmacy, a blood bank, a training program for health outreach workers, a 104-bed hospital, a women's clinic, and a pediatric care facility. It's the only healthcare provider for hundreds of thousands of peasant farmers in the Central Plateau. And more, it is a model that's being watched from all over the world for how to deliver health care to poor communities. Dr. Farmer is the co-author of over 100 scholarly publications and books, several books, including one recently published, Pathologies of Power, out in 2003, also Infections and Inequalities, 1998, The Uses of Haiti, 1994, AIDS and Accusation, 1992, and he's also, this is relevant especially to us, it's all relevant to us, but he's also co-editor of Women, Poverty, and AIDS, 1996. He's received numerous awards and honors, the Duke University Humanitarian Award, the Margaret Mead Award from the American Anthropological Association, the American Medical Association's International Physician Nathan Davis Award. In 1993, he was awarded the John D. and Catherine T. MacArthur Foundation grant, the grant that is known colloquially as the Genius Award, in recognition of his remarkable work. And his biosketch says, and I think he takes special pride in, a recent award, perhaps no award that better typifies his life and his accomplishments than the Heinz Award for the Human Condition, which he received from Teresa Heinz in 2003. In accepting it, he reminded us all that, quote, as members of the world community, we must recognize that we can and should summon our collective resources to save the countless lives that were previously alleged to be beyond help. He believes that we can do no less than this, and his whole life and his whole career has been dedicated to exactly that. It's just such an honor and such a privilege and such a joy, Paul, to welcome you here to Wellesley College. Thank you so much for coming.
Thank you. First, let me start by apologizing for being late. About that halo, it evidently was not much appreciated by the policeman on Route 16. And you think I'm making that up. And I was, all I asked is, please don't let the Director of Partners in Health know I was late. Just don't tell her. Because she couldn't be here today, which is a great relief to me. This is how it is when you have friends of many years, in this case 20. I remind her 23 years, and she says, well, I was only 10 when I met you. But she told me just a couple of days ago, more than once, we have been, the Director of Partners in Health, Ophelia Dahl, and I'm not sure that you know this, but we've been in Rwanda and Kenya and South Africa and Haiti, and just returned last night. And I just returned last night. She's not back. And she said, you know, Susan Sontag gave this talk. You better not mess up. So I'm actually secretly relieved that she's not here. I am thrilled to be back. I say back because I actually first came here when I was 18 years old. One of my best friends from high school came here, and you'll be proud to know that her daughter is here today. And her grandmother went here too. And when I arrived and I saw this place when I was 18 years old, I thought, I would like to go here. Could I please transfer? And so I've always wanted to go to Wellesley, and I appreciate the chance to be here. It truly is an honor to be here, and you're very fortunate to be in this this island of decency in a world which I'm sure, harkening back to Catherine M. Porter, you know, I still feel that metaphor is an apt one, that we are on a ship of fools, and you know that there's so much that we all need to do to, you know, each of us to make this ship not run aground or worse, founder entirely. And it's places like this, I think, where one has the chance to have a little bit of remove and yet to contemplate the major problems before us. And I'm very honored to have been invited. I hope I knew I'd do this. It's working. When you're talking about human rights, which I'm going to do, I think one of the biggest problems. There's Melissa's father. He's going to be mad about the ticket, Melissa. Really mad. It's all my fault, by the way. It's completely my fault. I just want to say. You think I'm making this up, but I'm not. When you're talking about human rights, dear colleague, I think it's difficult because it seems so removed from what we do every day, and yet it isn't removed. And so I'm going to try and talk about human rights by focusing on both the specific and the general. You know, obviously human rights are general concerns. They're of interest to all of us because we're human, and that's why we call them human rights. And yet, in everyday practice, everyday life, not medical practice, but the practice of everyday life, it's very easy to forget that these concerns are really central to what it is we do, no matter what we do. Teaching, seeing patients, learning, being part of an activist movement, being part of a broader movement. And I had the great privilege on Sunday, which was Easter Sunday, for me, of reading a remarkable book. I was in Haiti, and Sunday is, many years ago for me, was a day often like any others, but now, 20-something years later, and by the way, the Wellesley grad was there in Haiti before me, as she is apt to point out, although she does that less commonly now that the years have so long, and she doesn't want people to know that, yes, it's been 20-something years. Nowadays, we have a big staff. We have a Haitian staff, and some of my colleagues are actually up at Harvard today. They arrived last night also for a conference that brings together some of our African colleagues and some of our Haitian colleagues. And on this past Sunday, I did not go to work and did not go to the hospital. I read a book called Bury the Chains, which is a book about the abolition of the slave trade in England, a movement that began in the late 18th century. And I think I'm going to find myself referring to it several times tonight, because here's a movement that was just that, a movement. The book was by Adam Hochschild. Of course, the scholarly persons immediately take out their notebooks and write down I forgot the publisher. But it's a movement, it was a movement really that it drew in the ordinary citizenry of England. And in fact, that movement was really sparked when the women's movement, which was nascent at the time there, got involved in the struggle for the abolition of the slave trade. And it's very interesting to read this book. First of all, it is, as Ophelia Dahl might say, simply gobsmacking to read, and to read about the personal epiphanies of some of the people involved, because some of them were involved in the slave trade. Most were not. Most were just like all of us here. They were not directly involved in what was a crime against humanity, and remains a crime against humanity wherever it's practiced. But when some of the people in the women's movement got involved, they said, no, we cannot push for gradual abolition of slavery. We have to abolish slavery now. And I recommend this book to you strongly, because when we're on a ship of fools, it's easy to forget that movements engaging all of us, engaging citizenry, are what can change the world. And so it is with the examples that I'll give you, which are going to be medical. And not because they need to be medical, because that's where I can shuttle between the generalities and the specificities. Others have noticed also, however, that healthcare inequalities are able to move us in ways that maybe some other inequalities do not, but should move us. People feel connected. And some would hypothesize it's because anybody could imagine being sick and not having someone to take care of you, or someone you care about, a loved one, being sick and not having access to care. And I think that's why Martin Luther King said this, that this is the most shocking and inhumane of inequalities. And another general point from a document that I actually hadn't read, I'm ashamed to say, until a little bit late. I was on my way to Moscow to a conference to celebrate the 50th anniversary of the Universal Declaration. And as every teacher here knows, every professor here knows, students will keep you honest. And I had a first-year medical student from Harvard working with me to prepare, and he said to me, well, you know, if you're going to give a talk about the Universal Declaration of Human Rights, you might want to read it first. So I said, thank you, that is a good idea. And I did. And I found these two articles, which I think speak directly to anybody who's involved in science or teaching or the production of knowledge, which many of you are here, or in my case, frontline medical worker, reporting from the front, again, to go back to the Wilson Lecture's original intent. And I read through all of it. A lot of the language was really not about the kind of rights that I would call, and many others would call, social and economic rights. But that's what these two articles are about. And you know, I discovered later, shortly thereafter being rebuked by my student for not having read the document, that in fact some people call these poor people's rights, the rights of the poor. The right to health care, the right to housing, the right to a roof over your head. And these are the generalities that I wish to put in front of all of you as I go to a very specific example, one that won't surprise you. This is taken from the British Medical Journal, which I know you all read every week, so you already saw this. But I remember 10 years prior to this came out in 2002, about 7 years prior to this, I remember seeing the same curves, but they were projections. And when I was thumbing through this journal, some of the names of our medical journals are just hilarious. Like the Journal of Gastroenterology, the main gastroenterology journal, is called Gut. The main heart and lung journal is called Blood. I mean, there's some really creative ones. Anyway, this one is the British Medical Journal, and as I was thumbing through it, I thought, oh, it's just the same old chart that we saw years ago, but it wasn't. This was not projections. This was what had happened. And so the The terrifying thing about these curves is that they were predicted many years before. And if we had nothing that we could do, if there was nothing we could do, and I suppose this is what some people must have felt about universal suffrage, the women's movement, slavery. There's nothing we can do. People must have felt that way, right? I mean, otherwise it would not have gone on for, centuries, more than centuries as far as slavery is concerned. And yet we know that that's not the case. It wasn't the case in retrospect. It's easy to believe that it was the case regarding the slave trade. It was easy to believe that people believed that. It was rather difficult to believe that people believed that. But nor is it true that we could do nothing about this. And here's notice, log in your minds the shape of these curves. And here's another set of curves. But these are not decreased life expectancy. This is a curve of decreased death expectancy. Now, many of you know that our country, and I'm speaking as American whenever I say our country, does not have a great healthcare system. We have great hospitals, and I'm lucky to work in some of them, or one of them. But we don't have a great healthcare system. We have 40 million, some people say 45 million Americans who have no health insurance, and it is said by the Institute of Medicine that just as many don't have regular access to care. Regular or good health insurance, 80 to 85 million people in this most affluent and powerful country. But even with all the flaws in our system, look what happened to these mortality curves. This is, the jargon is that this is incidence of death among those already living with HIV. Obviously, something radical happened. And if you look at the blue curve, which does not involve a change in case definition, by the way, as an aside, since I'm at Wellesley, where truth has been spoken to power on many occasions around issues regarding gender inequality, one of the major parts of the case definition, by the way, was the inclusion of cervical cancer as an AIDS-defining illness. But go to the blue line. As opposed to the yellow line, you'll see something very dramatic happen in about 1995. And I think everyone in this auditorium knows what that was. And that was the development of what, I was just going to say what nerds would say. I'm not sure the initial intent of the Wilson Lecture was to permit people to say things like nerds. But if we have journals called Gut and Lancet, then you can imagine this is an interesting crew, the medical crew. But something interesting happened in what nerds would call combination chemotherapy for AIDS with what most people call antiretrovirals. And there isn't anyone who trains, actually I believe a couple of my former students are here tonight who are physicians and Wellesley grads. None of us doesn't know about the impact that these drugs can have. And none of us also doesn't know how they can be used unwisely. I'm just looking around for my Wellesley grad doctor friend, but I was just thinking about some of the cases that we saw together when we were last on service at as I said, a wonderful teaching hospital, and I'll return to this if I have time and don't get another ticket. If you look at what happens now, people who end up in the hospitals here, like a Harvard teaching hospital, sick with complications of HIV disease, are mostly women and mostly people of color and mostly people who don't speak English as a first language. When the drugs are used and used wisely, they actually, of course, have an effect, and that is that they suppress the virus. And the analogy to keep in our minds as AIDS actually becomes less of a problem in this country. Fewer than 400 children died last year of AIDS in the United States, I think, is the number. This is a disease that can be wiped out among children. But it can't be wiped out among children if there's not good HIV care for women. And you can't give good HIV care to women if we don't have good primary health care for everybody. Back to this curve. This was obviously something very dramatic. And I remember in 1995, I went from Haiti to Vancouver, Canada. Now, some of you may have guessed that there are no direct flights from rural Haiti to Vancouver, which made it a rather jarring trip, because I only went there for one day to give a presentation, actually on women, poverty, and AIDS. This was the year that the book you heard about was published. It would have been 1996. And I remember the theme of that AIDS conference was One World, One Hope. Everybody was excited. 1996, the year that it was clear that there would be a radical drop in mortality. But some Africans came to this conference with a banner that said, One World, No Hope. Because they knew, they predicted in 1996, that were effective therapies developed, they would not be used equitably. And sure enough, alas, that prediction, like the curves that I mentioned from the mid-90s, came to pass. Now, why is that exactly? We know that the world is an unfair place in which there are innumerable inequalities that sculpt one's chances to have access to something like this. And, something like this could be insulin for a diabetic. If you're a diabetic in rural Haiti or rural Kenya, where Ophelia Dahl and I just were visiting patients, it's a death sentence. You have to have, in the late 20th century or early 21st century, the tools of the trade to do a good job in medicine. It doesn't work without them. I just, every time I hear suggestions that we find some culturally appropriate way of treating AIDS in Africa, I know that they're not really talking about culture. People will say that. They're really talking about economics. They mean an economically appropriate way, which means let's not spend any money where it's needed. And how do we have this discussion which is not an honest discussion, about finding ways to not deliver high-quality care? How do we have that discussion in my circles, the circles of medicine and policymakers? Well, this is how. I've taken the names off these abstracts, and again, I know you all read The Lancet every week, so you've already read these, and you probably put them on your refrigerators. Do you have refrigerators in the dorms here? Of course you do. I know you did. I knew that. Not that I've ever been in a dorm, I promise. I have, So, if you look at these, I'm just going to ask a question. I've taken the names off because I wouldn't want whoever wrote them to think that I was picking on the authors of these papers. And I remember very well reading these in abstract form in central Haiti using the internet. And which, again, I know you guys are every night logging on to the Lancet website, so you read them also. And I could only see the abstracts. I could not see the papers. I couldn't access the papers from Haiti. So I was working with a brilliant young woman who had just graduated the year before from Harvard College, and she was a full-time research assistant at Partners in Health. And I wrote her an email and said, Nicole, would you find out what the references for this are? Because look at the first one. It says it's 28 times more cost-effective to do one thing than the other. And there's a curious specificity to that, don't you think? I looked at it and thought, by the way, what does HART mean? I'm sorry, I should be defining these things. Some of you know, but it means highly active antiretroviral therapy, so the drugs that we're talking about. So I looked at it and I thought, wow, in 2002, we've just spent 4 years trying very hard, the we here is again Partners in Health, and trying very hard to make sure that people living in poverty in Haiti who also have AIDS can have these medications. And it's not easy. It wasn't easy to do. It's easier now than it was in 1998 to 2002. But it was very unpleasant, and because it's hard to find the money. It's hard to find the money to buy the medications which were patented, and I'll show you some figures about costs in a minute. But I thought, is it really that big a split? Because doesn't that make you? Let me put it this way: you read these. A couple, and my students, former students who are here, and they can also vouch that I'm never late to class. They could stick up for me, I think. I hope they will, being Wellesley alums. If you're doing this work, which is very difficult, and you see something like this, and you silently ask yourself, now, is this meant to start a conversation or to stop it? And that's what I read some things or hear someone giving a talk about policy. Now, you're going to hear me talk about the same things, drug costing and infrastructure and all the things I'm going to talk about the same things, but I hope that everyone here will know that I'm doing this to start a conversation, not to stop one. And sometimes I read these things and I think this is really a conversation stopper. It's to halt, because the first thing you'd want to know is, why exactly are the drugs so expensive? Or is there anything we could do? Or are there not interventions we could we could make in order to make this work for people living with both AIDS and poverty and gender inequality and the long list of the social factors, racism, that drive forward this disease. Now here are the numbers for you. I'm actually came here with one of my co-workers, Melissa Galuli, who is works on both the Haiti project and we'll be working on. Am I allowed to say you're working on the Rwanda project? Oh boy, I forgot. Maybe you should tell your parents that before I do. Too late now. She's working on the Rwanda project. Anyway, when I say we, I mean Partners in Health, and Melissa's been very involved in this as well. This was average wholesale price for a 3-drug regimen, and for those of you who enjoy nerdish discussions of regimens, I've put what regimens they are. A 3-drug regimen, average wholesale price, the same year those 2 abstracts were published, the same summer, in fact, because I asked Nicole, who fortunately now is a grad student in public health policy, so we're fighting back. But that summer, I said, well, can you make a chart and just find out how much Partners in Health is paying with a mix of generic and concessional prices? You can see PIH there, that year, 2002. And then compare it to the average wholesale price for the same 3 drugs. So, and then the other 2 numbers, I'll just say they actually came later. One is the IDA, which is the International Dispensary Association, where we convinced our colleagues in the Netherlands, where they're experts in drugs. We convinced our colleagues in the Netherlands to procure antiretrovirals for us because they said, well, there's no market. Now, can you imagine? The leading infectious killer of adults in the world, and the first response is there's no market. Something wrong with that formula. So we said, well, we'll make a market. Help us out here. And they did. And then, more recently, the Clinton Foundation, as in William Jefferson Clinton Foundation, got involved and renegotiated the prices again. And so, and Melissa will correct me if I'm wrong, but I think this is the price we expect to pay this year for the same regimen. Now, I'm delighted, as would anybody who would benefit from this intervention. But harken back to that previous slide. It suggests, of course, that this is a static problem. If something that's 28 times more cost effective than something else, you have to know the cost and the efficacy or the effectiveness. And these papers don't lead you to believe that there's a rapidly changing situation. But this chart, which is not a projection, by the way, remember I said I couldn't read the paper, and I asked Nicole, where are they getting these figures? What studies? Because I didn't know that there were projects in Africa in 2002. And she went right to the footnote, as any good scholar would, and found that in the first paper, the 28 times more effective, the curious specificity paper, one of them was what's called a modeling exercise, not like on a Milan catwalk model, but a mathematical modeling exercise. And the other one was projected costs from a project that hadn't even started yet. So, interesting source of interesting data, and fine. I'm glad to see, but ours is not a projection. Ours is what really happened. Now, that's the background for this more specificity, from going from this big, grand human rights statement, quoting Martin Luther King, and going to the specificity of medications. Now let me just go to what anthropologists do, specificity of place. Doctors do that too, because we usually are taking care of people. And this is my trajectory. This is the one I just made. It is the Brigham and Women's Hospital, and it's a village in rural Haiti. And, this is a jarring exercise, I'll tell you. And it's not just because it's bone jarring as the road, but it's jarring to go from one extreme to the other, and to do it many times in the course of a year over a couple of decades is particularly jarring. And I mentioned going to that meeting in Vancouver, and on the way back to Haiti, I thought, how long will it be until one of my Haitian patients asks me about these new drugs, as they were called at the time, the new drugs? And the answer was, as soon as I got off the plane. In fact, the person who picked me up at the airport, a Haitian, in fact, there were more than one that picked me up at the airport, said, we heard about these new drugs on the radio. When do we get access to them? So that was the answer. And that's the way the world, and many of you know the world, you move in the world. And I mentioned with admiration this island of decency. But of course you sally forth and see the world as, and see parts of the world that I do too. And of course, and you know that this is an interconnected world, a world in which information travels like this. And here's another reminder of the way the world is. This is what I have to look at every time I leave a squatter settlement in rural Haiti. Some of my friends here have seen this slide before. I'm accused of overusing it, by the way. I ignore my critics. This is a hydroelectric dam 8 kilometers from the squatter settlement where we really founded Partners in Health. A squatter settlement that looked at that time like the picture I just showed you of a really immiserated dwelling. I just came from this meeting I mentioned with Haitians and Africans. We had a meeting on AIDS at Harvard, and one of my coworkers, a very interesting fellow who now directs something called the Project on Social and Economic Rights, grew up in great poverty, one of 22 children. Told me, well, he actually told a journalist once who was visiting in Haiti, I didn't even have a pair of pants until I was 11. He got his first shoes in order to go to school. Anyway, now he's more likely than not, he came to this meeting, and he's more likely than not to send me an email from Haiti saying, I told you, I hate Windows 98. Please come back with Windows XP. That's the kind of email I get from him now. Anyway, an interesting fellow who taught me a lot. And one of the things he taught me is that his family and others who lost their land to that hydroelectric dam regard it with no small amount of malevolence. Talk about the ship of fools. You know, this is now a hydroelectric dam that, as you can even guess, I think, from the image, is being silted in because of the deforestation. And these people lost everything when this valley was flooded, and they resent it to this day. And maybe we'll have a chance to talk, and I definitely want to leave time to talk, about how that sort of resentment is related to some of the violence and terror that we see in the world today, because I think many of us will agree. Now, since I was exceedingly late, I'm going to skip through some of these numbers and go back to the specificity of Haiti. And I want to talk about ever shrinking down from Martin Luther King and the Universal Declaration to drug pricing to a place. What's it like to have AIDS in a place like rural central Haiti? Well, we decided early on that, and again, it was that year, 1996, when we started having a lot of soul searching. What are we going to do? That was the year, as was kindly mentioned. I thought my mother was the only person who read Women in Poverty and AIDS. That was the year we wrote that book. And you know, when you write books like that, and you make arguments for a rights-based notion to something, you can kind of trap yourself into doing the right thing. That came out wrong, actually. But you know what I mean? You say, well, healthcare should be a right, and then what if you're in Ophelia Dahl's position as the director of a fairly rapidly expanding charity? You'll be proud to know, by the way, that she was recently giving a talk at Stanford University, and they asked her for her CV, to her amusement. And she said to me, I've only had one job, because she's been doing this for 20 years. And how would you feel if you were she? How'd I do, English professors? How would you do if you were she and you had to make hard decisions with the money that you're raising from, you know, most of our contributions come from private contributions from individuals, and you knew that, for example, it cost $10,000 to average wholesale price to start a project like this. It was very difficult and very painful, but we decided that we couldn't really maintain, none of us who were making that trajectory between immiserated Haiti and Boston in one day, we couldn't maintain just emotionally. The tension was unbearable. You know, I would get off the plane in Boston and beg my patients to take their medications, and I'd get to Haiti and have the patients begging me for the medications. Often, on both end of that spectrum for me, I'd have Haitian patients in Boston and Haiti. I didn't even have the privilege of a language change. And I just found it untenable, and so did Ophelia and other decision makers at Partners in Health. And so we launched something that we called, rather sassily, in Wellesley fashion, the HIV Equity Initiative. That's what we called it. And it didn't translate very well into Haitian, I might add, but the Haitians loved it. You know, I learned so much from the Haitians, and I hope some of you are Haitians here today, some Haitian American students perhaps, but I've learned so much from the Haitians. And when you read that book, Bury the Chains, about the abolition movement, you'll see just how important the history of your country was, or that country, for those of us who are neighbors, longtime neighbors of Haiti, as every American is. And I learned a lot from the Haitians, and one of them was that it was a good thing to push for equity. And I wish, you know, I don't wish I could take credit for these ideas. That sounds self-centered. But I can't, even if I wished I could, because these ideas come from the people we serve. And they said, well, you know, if the drugs cost too much, then figure out something else. Find another way to, they didn't mean another therapy, another way of getting the medication. So we did. We even worked with patients here in Boston who had changed their regimens and had unexpired medications. That's how difficult it was to start. We had more assistance even from people living with HIV in this country to help us do this. But now it's a big project, and the numbers aren't that important. They're important, but they're not as important as the experience, as I said. This is what it looks like. This is what the project looks like. It doesn't look like a list of statistics and the ones I just shared, for example, with my colleagues at Harvard and the ones from Africa. This is what it looks like when it's working well. And again, this picture, and I know I'm going to have to speed up or then there will be no time left for discussion, but this picture is another one with a story. I didn't take it, and it was taken by a New York Times photographer, because a New York Times reporter contacted me by email, and she wrote, I'm writing about ARV scale-up in Africa, and you know, it just really seems to me that it's not going to work well. And I said, well, don't write that yet. Why don't you come down and visit? She said, okay, when? I said, tomorrow. Now, note to self, do not say that to a New York Times reporter. Because she showed up the next day. And so we scrambled around. Later, now I've read a lot of the things she's written. She actually covered something called the poverty beat, and she called it that. And some of you have seen her articles about the brain drain in Africa. Her name is Celia Duggar. And she came down to Haiti, and I think she would say, if she were here, I'd still tell the story exactly the same way, that she came a skeptic. And she wanted to spend, that's her job. I did point out to her at one point when we were having a beer, would that you had been a little bit more skeptical about those weapons of mass destruction. And I said, now why did I do that? Let's get back to AIDS. Anyway, so she was a skeptic, that's her job, and she spent a lot of time with the community health workers. And one of them was a woman named Margaret, and she's with the one with the hat. And so a month goes by, however long goes by, this photographer comes down, and this is December 2003, and the article appears in the paper. And someone said, and it's above the fold. Now, I didn't understand the significance. I'm still not sure I understand the significance, but they were very excited when they said that. This is not the journalist who's pretty laid back, but it was above the fold. So I got a copy and I brought it to Margaret, Margaret, the healthcare worker. And I said, and it's above the fold. And she said, oh, that's interesting. I said, well, I have a copy for you. She said, okay, fine, you can just leave it right over there. Anyway, I need to talk to you about the patients. And I couldn't get her to be interested. I said, you can even look at the pictures on the internet, and as I've already hinted that we put in internet in Haiti, and I showed her a series of pictures, and that was the only thing that interested her, not the picture of herself, which appeared alone on the cover above the fold, New York Times. It's a picture of her striding across this territory with all the bags for her neighborhood, all the medications for her neighbors with AIDS in her bag. She's visiting them every day and giving them their meds. She liked this picture though, because she said, if you look at that picture, you can't tell who's the patient, who's the health worker. Only I could tell you. Because all my patients look like that. And that was the end of that story. I couldn't interest her anymore. And why was she was blasé about being in the New York Times because she wasn't that interested in the New York Times. No offense to those of you who have worked there or whose parents own it or something. But not everybody reads it. I know the demographics of this place. But the impact of some of these experiences on patients is profound. And in fact, I heard a story. I was told never use religious imagery at Wellesley. It's against the law. In fact, someone told me that I would get an electrical shock if I did so. I'm kidding. No one ever told me that. But we had a patient. I'm just getting warmed up. This is bad. But I just will say, I heard so many patients tell me about, they would say, I'm a second Lazarus. And the first time I heard it, I thought, well, that's really, in fact, I got all choked up hearing them tell the story. Then I heard someone else say, I'm a second Lazarus. Then I realized it's what we anthropologists call a cultural narrative form. And but let me just show you, and I'm not going to apologize for this image, because again, I've shown you the happy side, and there's more happiness, but this is what it's like for us to see people come in, dying young people. This is a 25-year-old and his mother. And again, since I'm at Wellesley, remember that care for people living with HIV is very gendered. Free labor from mothers and aunts and sisters in this country, as in many others, free labor. It's very hard. And I'll close with a story from Kenya. But this is very difficult, mostly, obviously, for someone who's dying of the disease, as this man. This man dying of two diseases. And I think some of you will know the second one is tuberculosis. He's got AIDS and tuberculosis at the same time. Leading killer of people with AIDS is TB. And his mother, who said, nah, let's not give up just yet. In fact, I was called by one of my students who actually has given a talk here, I believe. He's been out here, Dr. David Walton, who took this picture, and one of his colleagues, I think, is here tonight. He's in Haiti now. But he called me, or sent me an email and said, can you come and see this patient who's really critically ill? This is about an hour and a half from where I live. And I said, sure, I'll come. And I showed up, and I saw him looking like that. And he said to us, he could barely talk. He said, I don't care. I give up. And we said, no. His mother said, no, come on. We chivied him along, and he started medications. And this is the same fellow 6 months later. Now, if this happens to you once in your lifetime, as a nurse or a doctor or a social worker, or as you are, a group of people who can look at it, just one time. But imagine if you could do that again and again, as you can do, as we can do. We can make a difference like this in people's lives. And indeed, we do. And the big question is, not only did this man recover, come back from the brink of death, but guess what he did next? He became an AIDS outreach worker. And this picture, taken by the medical director of Partners in Health, whose name is Joya Mukherjee, she took this picture at a conference last year. I think you were there. And he actually, you see the picture of him. He's projecting an image of himself. And when I showed him this written thing, this was written by the World Health Organization, I gave it to him, and he said, "Yeah, I'm famous. I'm a star." And so he is. But he's one of many stars. And we learned many lessons in doing this. And I'm not going to go into the details now. I want to talk about it. And we learned lessons about how to deliver the care. We learned lessons about public health. We learned that if we listened to the patients, they were going to start telling us, as this young man did. His name is Joseph. I'm going to call him Joe. Not to distance him in any way from us. I interviewed him, and so did someone else, and I was transcribing the interview into English, or transcribing and translating, because not that many people speak Haitian except for Haitian. So our colleague from the World Health Organization said, I want some images. He'd already seen the images of this guy. I want some interviews with patients. And I said, does that mean I have to translate it? And of course it did. So I did translate it. And I listened to his voice, and I'm hitting rewind and listening. And the interviewer, who was a Haitian fellow, said, what do you want to do now that you've had this experience? He said, I want to learn how to read and write. That's what he said. He said, it's stupid for someone my age, 25, grown up, to not be able to read and write. And he is now an outreach worker, and he's learning how to read and write. And again, when we listen to patients, we hear them talk about their children, and we hear them talk about water and their housing and learning how to read and write. And so we have tried. We are Partners in Health, and these are our colleagues. Actually, this fellow is a physician, Dr. Almazo, and the group of people rebuilding that house, those are high school kids from Conch who are volunteering for the summer. It's not only about Partners in Health, people like me. It's not even largely or about people like me going there. This is about what we can do together in building a movement. And what will happen if we don't build a movement? I mean, again, having read this marvelous book on Sunday, you just wonder. It was bad enough that it lasted that long. And you read here when you're here. You learn about movements. What happens if we don't act? What is the cost of inaction? I say social cost. I just assume that, yes, we can cost out as economists, but the social cost of not doing the right thing. And Ophelia Dahl took the next picture, and I'm actually in the back about halfway through that. I don't know if you can. But we went 15 months ago to these same villages we visited last month. And it was very disturbing. I'm happy to tell you it was a great trip last month because we saw that a lot of the recommendations that we made, that Ophelia Dahl actually made to the group we were visiting, a lot of the recommendations had been followed. But we went there the first time. It was heartbreaking. Now, this is a school, so of course it's full of kids, but leave the schoolyard, and it's still only kids and older people. There's no young adults. Their parents are gone. And I saw this in, again, Ophelia took the picture, but this was inside a school, and I know what the teacher meant by writing "save" at the bottom of the screen. It reminded me of when I was growing up, but it's not what I saw. I saw what I think you can see in this image, that in order to save Africa and other beleaguered places, that a movement is necessary. And I'd like to just address myself in closing to the students here, and most of you, I assume, Wellesley students. This is another of the places we went, a health project, but abandoned, really empty, abandoned. And it was like this in many of the places we went. By the way, last month, this same place was bustling, was full of people. So the story last month was a very much happier one. But 15 months ago, it was heartbreaking to go there on the shores of Lake Victoria and see the way that too much inaction or too little action had led to such a devastating effect. But then on the way out of Kenya, we stopped and visited another project. And that one was a project in which modern technology, the fruits of science, again, think of that human rights argument, what was being used. And this was in Maasai land, even poorer, really, in some ways, a pastoral people who move around a lot. Try treating a chronic disease when people are moving. It's not very easy. But they were. And this, I had nothing to do with buying this box, but you can guess what's in it. In fact, I was in the plane that delivered it was one of those little planes. And I'm embarrassed to tell you that I was what I said on the plane ride. There was a Kenyan pilot, Ophelia Dahl's in the front, I'm in the back, and there's these big boxes of antiretrovirals. And as we approached the place we were landing, we had to buzz the airfield. It was grass, so that the animals would move away. And I looked down and I said to the pilot, "Is that a giraffe?" And the pilot looked at me and thought, I could tell he was thinking, well, what else could it be? And what else looks like a giraffe? He just looked at me and said, "Yes, doctor, that is a giraffe." So, anyway, once I felt like I just rolled off the turnip truck. I'll tell you when I got to Maasai land. But what I saw there, and what I'd like to share with the students, and this is my last image, is, now I'm realizing I think it's probably a gendered image. Is that these people in this area, this is one of my Kenyan colleagues, had made a choice that they were not going to start by trying to dumb down the standards of care. They were going to do their best, and there were Americans involved, I'm proud to tell you as well, who had fought, an American woman who herself had fought to raise the standards of care. And when we went to visit Maasai with AIDS, who were in their little places called bomas, we found them all doing very well. And the message for the students, I just want to say that I think some of this is in our hands. Thank you very much, and I look forward to debate. And thanks for your patience.
So let me just explain. We have two microphones. The floor is open for questions or comments. Well, there are 2 overflow rooms, which is the reason we
my
have these
heavens.
big lights.
They must really be cursing me. I got late. They're late.
No, they're fine. So feel free to come on up, and we'll take turns. And why don't I leave it to you to
Okay,
call on
no
you.
problem. Thank you.
Hi.
Hi.
I'm 15 and in high school. And
You got your ID?
Actually, I do. So I'm here with my group of people. Some of them are back there also. And we want to do something, but we're not exactly sure what we can do besides, having bake sales and sending in money. Is there anything?
Well, I was recently at a school heavily populated by 15-year-olds, and under, I might add, and in fact, there's enough people here, so I'm not sure. Some of them may be here tonight. I had heard that they were coming, and on the way to that school, first of all, that school had done a number of things. I mean, this sounds self-serving. The reason I met them, of course, they did a lot of things with Partners in Health. I think, and correct me if I'm wrong, but last year these 15-year-olds that or thereabouts raised $15,000 for Partners in Health. Another group of kids, even younger than 15, have just started a campaign. And again, I think maybe their parents, who are friends of mine, may be here somewhere, hidden somewhere. But they just started a campaign. I kept on looking and said, what are all those yellow bracelets people are wearing? Have they been inpatients in a hospital I don't know or something? What's going on? And I later discovered that it was this Lance Armstrong thing. There you have them on. Well, my friends just started a campaign in which they made, if I'm not mistaken, lime green ones that say on them in Haitian, "Tout moun c'est moun," everybody is a human. And they just started a campaign. These are kids, and and some of them are younger than 15, I might add. In fact, most of them are younger than 15. And of course, I'm thrilled that the other group that they've done marches, they've done walks, they've done all this stuff. And I was thinking, I didn't say this out loud in their school, but I was thinking, what was I doing when I was 15? Actually, one of my friend's children, Hope, does not think about that too much because she's a Wellesley student, and her mother was also out of control. But I wish we had been doing things like that when we were 15, like these other people we've met. So I think there's so much we can do. And then, I mentioned organizing, which sounds like a grand word, but, you read this book about the end of slavery, which was first started, by the way, remember I said they abolished the slave trade because they were frightened to say, well, let's abolish slavery. It was the women's movement that got involved. Women, some of them were Quakers, and when they got involved, they said, all right, already, not just stop the slave trade, stop slavery. And again, this was through organizing. If you read this book, and I promise I'll stop, and hear about this fellow, Thomas Clarkson, and the epiphany he had. First of all, how would you organize and move 10,000 miles in England? By horse, of course. Wait, I didn't mean to rhyme, but it wasn't easy to do, to ride around on those pretty bad roads on a horse, tens of thousands of miles, visiting people. They started a sugar boycott. They had petitions signed by 750,000 Britons, ordinary people, as the book says. So never believe for a minute that you can't get involved now. And that's, if I have a regret, it's that I wasn't involved when I was 15.
Thank you very much.
Good luck.
It's a very accessible picture.
Thank you. Teenage boys always say that.
Hi, my name is Katie Chan. I'm a senior at Wellesley College right now. Basically, Wellesley likes to send out a lot of her students to all parts of the world for summer internships, for winter internships, and even after graduation. But as you said in your most recent book, we're really basically taking our agendas that are imported from capital cities, from do-gooder organizations, and from universities with the right answers. And we've been so well educated in institutions like Wellesley College, and we really do have good intentions when we go out to like Peru or to Haiti or wherever, but it's hard for us to break down, I guess, our thoughts of privilege. And you as, I hate to say it, but a white, male, well-educated man do this very well. So how do you do this? And what do you suggest to, like people here who do have the intentions to go and do this?
Well, first of all, notice that in that, if I was going to say, did I write that?
Yeah.
But notice in there, it's first person plural, right? It says we. I'm sure it must say that. I hope it says that.
I think
It doesn't say they, because of course it's a self-critique. That's at the, I think at the end of the book, that book. It's a self-critique, auto-critique, whatever. And I think it's an exercise that's useful, you know, and starting early in auto-critique. But if I can quote the Wellesley alum I've been quoting many times, my coworker, I saw her on a television program, and it was one featuring Thomas White, who is 85 now, and said about 20-something years ago to me and to Ophelia, I'm going to back these efforts, and I wouldn't mind dying a poor man. Now, on my way back from the airport, last night I went to see him. He's 85, and he's getting there, meaning he's done what he promised to do. And Ophelia was giving an interview about him, and she said, and I may have been there when she said it, but I saw it on television and on tape, and she said, the greatest privilege is to know that you're privileged. And I just sat and watching the screen with my coworker's face on it and thinking, you know, that is a very profound thing to say or even think, is the greatest privilege to know that we're privileged. So I applaud you for recognizing our privilege. And that's the first thing that I think I learned in working in Haiti, and is that, you know, I don't kid myself like I'm a Haitian. I can get on a plane and leave, as I just have proven again and again, or Rwandan, or any of. I'm a privileged American, as you pointed out. Thanks a lot. But I think that's a great thing if we can understand that we're privileged, because many people with equal privilege or more spend a lot of their time bemoaning their ill luck, and you can imagine what that sounds like from Haiti, you know. And I mean, just to watch, you know, the American media from Haiti is a very it's also a jarring experience. So the first thing is to say, you've already done the diagnosis, which is the part that a lot of people have trouble with, admitting their privilege and their good fortune to be in a place like this. And then, you know, the next steps, so they're going to be different for everybody, of course. But the next step is, you know, to ask, what as a person of privilege might I do to make, you know, I've given this example of making slavery end. That was a feat of organizing. It was not. Now, would it have happened if there had not been the slave rebellions in Haiti particularly, but also in Jamaica and Barbados and other places? I suppose scholars would say no, it would not have happened. But the role played by people like us, like you and me, if I may be so bold, people who go to places like Wellesley or Harvard, was also very significant. Who do you think compiled the information to submit to Parliament, the Houses of Parliament? People like us, people who could read and write, people who could go find that famous image, the famous image of the slave ship. That came out of that movement. They found it. They went, aha, People's Exhibit A. And, you know, that image is still in our minds to this day. Someone just said to me in a meeting like this, you know, healthcare as a human right is difficult because you don't have an image like the ship. I didn't say what ship. I knew just what they were talking about. But I said, and I didn't mean Keanu, that great thespian Keanu Reeves. I meant, yeah, we do have images. We have images of people who come back from near death. And I think, do what you're doing. You know, be self-critical. Understand that we're privileged. Or, you know, engage with these problems. You know, and I teach medical students, so one thing I always say to them, and I think I have witnesses in the crowd today, is, but don't forget to study medicine. You know, don't forget that you're also here to study and to learn. And, you know, activism from us is most effective when it's informed by knowledge and evidence and documentation. So I would just say, do what you're doing. And Wellesley, to send forth, you know, its best and brightest to take on these problems is a gift. It's not it's a certain kind of gift. It's a gift of the privileged, and it should be recognized as such. But it's a gift nonetheless. So thank you.
Thank you very much. I'm Jody Mikulachka. I teach in the English department and remember your brilliant director very well. I wanted to ask you if you could say a little more about what you felt you've learned from Haitians and from being in Haiti where you went as a young adult, and how you feel that your own vision and what you've been able to do was shaped by the experience that you've had in that country.
Thank you. Well, first, how was my grammar? First, I think that my vision is very derivative, and there's no shame in saying that. At least I've experienced none. And we're proud to have learned from others. The idea that is emblazoned in the Partners in Health website of a preferential option for the poor, that's borrowed from other people. We didn't. We never. Structural violence borrowed it from, and some here, my colleagues who are anthropologists might not even think it's a good term, but anyway, it's derivative, whether it's good or bad. And the idea that I have to say, I'll say something. You've asked me a personal question. I'm going to give a personal answer. That being in Haiti as a young person and witnessing not only the misery, but also the willingness to fight back. The example I gave of someone who wasn't willing to fight back, he still had other people fighting for him, some people in his own family. But seeing the popular movement in Haiti and the response to dictatorship and the fight for the basic social and economic rights that I mentioned, I would say that has been the most moving experience of my life, seeing that happen, seeing the groundswell from 1985 to 1990. Now, granted, many horrible things have happened since in the last 15 years, but that does not erase, nor does what happened after 1804 erase what happened before 1804 in Haiti. Actually, there's a Wellesley professor who writes about these matters. In fact, there's a couple of them who write about these matters. One of them is Return to Haiti, a Haitian, and I think many people in Haiti, including people who, unlike this Wellesley professor, actually grew up and live and remain in poverty, take this image with them, the image of fighting, for example, slavery and racism, and now more, some would say more prosaically, but the everyday fight for food and wood and water, to quote a woman who told me what her everyday life was like, the fight for food and wood and water. And I think having that, learning that early, and I think it gets back to the previous question from the senior. Did you say your name? But anyway, you're a senior, so that's pretty high status anyway. So I think it gets back to that question of understanding how not just how fortunate we are, but how important that struggle is for equity. I learned that from Haiti, and I've never been able to shake it. And I know the director of Partners in Health would date her own conversion experience in terms of the fight for equity to those years and that experience as well. So I have an enormous debt to the Haitian people, and I won't pretend I could ever pay it back. I can just try to be authentic in talking about what's going on there now, for example, which is very unwelcome in many quarters, to try and be authentic and honest about what's going on there. It's very welcome in rural Haiti, of course, but it's not welcome in many of the circles I move outside of Haiti. So I feel that's the one way I can not try to pay back that huge debt of learning from them, but at least make it clear that I acknowledge that debt. Thank you so much.
Just for one more question.
Yes. Hello, Dr. Palmer. I've been following your career from the beginning, and
where were you tonight when I needed some help on the road?
Amazing. Actually, my name is Maymay Ellerman. I taught in the Italian department here for 12 years, and I've now moved on to other things. I was thrilled to hear you quote from Adam Hochschild's book because he's a friend of mine. I had just read it. And I am also on the board of directors of an organization called Polaris Project, which is fighting modern-day slavery, in other words, human trafficking and sex trafficking. And my question to you is, among the other horrendous I'm sorry, I just get very emotional about this. But among the abuses that the victims of sex trafficking suffer, and we're talking not only about those who live in Cambodia and Japan and East Asia and Africa, but also the many, many thousands here in the United States, including American children, of which there are at least 200,000 who are considered at high risk. And I was wondering, they too face incredible health concerns. Many of them, of course, become ill with HIV, AIDS, infected with all sorts of sexually transmitted diseases. And I was wondering whether in the circles that you frequent in Haiti, in Peru, and in Russia, whether you also encounter victims of sex trafficking.
Thank you. We certainly do. And again, I think, that sex trafficking is tied most tightly, of course, to social inequalities of various types, gender inequality,
yes,
and poverty, but poverty next to affluence. Sex trafficking occurs across these steep gradients of social inequality. And so, in fact, in every setting in which we work, we have seen evidence of this. One of the striking things about our most recent endeavors, which have been in and will be in Rwanda, is that, as you mentioned, the victims of sexual violence have serious health problems and social problems. So, just a figure that from Rwanda, it is estimated that of those who survived sexual assault during the genocide, that 80% who survived are living with HIV. And if you meet these women now, 11 years later, and which is not difficult to do, they are seeking medical care and also care for their children. And so our way of engaging these problems is often also by attending very closely to their current complaints, which are as often as not, in the case of people who are survivors of sexual violence, about, again, these basic social and economic rights, in addition, of course, to the civil and political rights that were violated by sexual servitude or gendered violence of any sort. The problem is particularly acute in urban Haiti, much less so in rural Haiti, where there has not been this disintegration of social. There has been, of course, and will continue too. I mean, you saw what happened with the natural disasters of this past year in Haiti. Those won't stop, and they will lead to other social disasters, including the ones that you mentioned. And so, one of the things that we've tried to do in our work is to adopt this stance of, again, believing that it's not a wise thing to fight for certain rights and not others. And so we have tried to avoid that. It's true that many of us are medically trained, and often our point of entrance is through medicine.
Medical,
but as you can see, we're interested in the grander struggle for all forms of respect for human rights. And that plague on all of us is, again, very much like it calls out for the same sort of organizing and struggle that it really did end the slave trade.
Yes.
So thank you very much.
Thank you very much.
I can't thank you enough for having me. It's just a privilege. Thank you. Thank you. I'm glad I was being late with my...
Yeah. So I just want to say, and to the people who are in the other rooms too, during your undergraduate years at Wellesley, you probably hear You probably go to 1,000 different events or more. I haven't actually counted. There's a lot that happens here on this campus. I hope this is one that you will remember for the rest of your lives, and I think it is. I hope you'll carry with you the memory, those simple slides, and yet so moving. And the question from Katie, so what do we do? What does this mean for us? I hope you'll go away and live that question, the privilege of our privilege in this island of decency that we're so lucky to be in right now. So what does this mean for us, for every one of us? There are things we can be doing. Every one of us, there are things we can be doing. So please go away and talk to each other about that, think about it, sleep on it. This is a very important moment and a very important message. So Paul Farmer, thank you so much.